Good afternoon, everyone. My name is Dr. Dominic Akaateba, and I'm with Ghana Medical Health. A happy new year to all of you, and welcome to our 2025 Maternity Service Agenda webinars that we would be holding this year at 3 p.m. every Friday, just like we did for last year. To start the year off, because of our area of operation, which is mainly in the Upper East, Upper West, and a bit of the Northern region, we look at a peculiar thing during this season, the season of Harmattan, which is asthma and the exacerbations that come in. And because this webinar series is mainly for maternity, those in obstetrics, helping our midwives, our doctors in maternity, as well as obstetrician gynecologists to have a discussion around it. So today we're having a topic which will be led by Dr. Jonathan Zumakpeh. Is on bronchial asthma in pregnancy. Kindly take note of the following housekeeping rules. You'll notice that once Dr. Jonathan starts the presentation, if you try to unmute yourself, you will not be able to. This is to prevent people from either inadvertently unmuting themselves, whether knowingly or unknowingly. However, the chat box is available throughout the presentation. You could put in your question, your comment, your suggestion in there, so that at the end of his presentation, which we are looking at about 30 minutes, we can have a discussion around it. So that's for us to be aware of. As well, because of network issues, we advise that you don't turn on your video. You realize that my video is not on and the presenter's video is not on. Our bandwidths are not that strong, especially those of us who practice in rural areas. So looking out for your neighbor, it will be helpful not to do that. If I find a couple of people with videos, I will have the unpleasant duty of turning off all those videos as well, just for us to be aware of. I also wish to announce that usually on Thursdays, same time, 3 p.m., we have a series of webinars as well on any other topic other than maternity-related education. So just take note of the same link that you used to join today, whether it's via the link that I shared or the meeting ID and password that was there at 3 p.m. either Thursday or Friday when you are available and you want to learn a thing or two for 30 minutes and another about 30 minutes discussion. You can use the same link. It never changes. It's always the same. So throughout this year, same link, same meeting ID, same meeting password, same link we'll use. So Thursday, Friday, anytime you're available, you could kindly use the same to join us for these our presentations. As well, we ask that knowledge is not in one person. And so we open the platform for all those who want to contribute to making this more effective. If you have expertise in any maternity-related field or any other field in medicine that you would wish to help educate people, to help discuss with people, definitely we are glad to offer our platform to you. So Thursday, Friday, I'll put my phone number in the link. If you are happy to do this, you can send me a message and then your expertise or specialty that you want to look at, and then we can schedule appropriately to have you do this. We cannot pay you for that service, but our donors have graciously been able to offer a 500 CD, usually to the presenter for airtime. We know that that's definitely not adequate for all the time that you use in doing this, but it's our own small way of saying thank you for your time, for the data you have used. So kindly take note of it. And if you can help us to improve upon the knowledge of all of us, knowledge is not in one person. We usually want to have discussion. Make yourself available. Today you may be the expert. Tomorrow you may be on the other end and seeking somebody to guide you. So if you don't teach, you don't train, and the knowledge is only in one person. If not, even you yourself, your relative elsewhere in a deprived area may need that knowledge which you should have shared. So let's help to improve upon medical practice. Thank you so much. So without much ado, I would welcome Dr. Jonathan Zumakpeh. Dr. Jonathan is a medical officer at the Wa West District Hospital. He's a great guy, and I'm sure he'll lead us through bronchial asthma and pregnancy. And like I mentioned, kindly take note of your questions, comments, and then at the end of it, we'll have a discussion. Thank you so much and Happy New Year. Kindly join me in welcoming Dr. Jonathan. Dr. Jonathan, over to you. You could kindly unmute yourself, Dr. Jonathan, and then you go on.
All right. Thank you. Good afternoon, everyone. As introduced by the absolute legend himself, Dr. Akaateba, I'm privileged to be here today to lead this discussion on bronchial asthma in pregnancy. As he rightly said, it's the season for some of these conditions, and especially in our pregnant women, they are not spared as well. It can happen to everybody once you have asthma. And the other aspect is that there was once a case we saw, and then and the patient herself had decided to stop medication because she saw online that frequent use of some of the medications is injurious to the baby. So she decided to stop. So she was brought in an acute state. So it's part of the reasons why this topic is also very important. So without much ado, I'll just go ahead with your permission. Our outline today is as follows. We'll have the definition and introduction, the risk factors for exacerbation in pregnancy, pathophysiology, phenotypes, differential diagnosis, the diagnosis itself, the workup and management, and then follow-up. One thing that is for sure is that everything else about asthma is the same. I mean, in the pregnant woman, is the same in the non-pregnant woman. It's just a few caveats that are guiding the principles concerning pregnancy. So those are the ones I'll be highlighting on more in this discussion. We'll touch a bit on the general ones, but basically it will be more on the skew towards the pregnant woman. So these are my references. I actually decided to bring my references first so that anyone who has these can actually be going through as I present, so that you can make a reference, and then at the end of the day, if there are any corrections, if there are any suggestions, you can bring them on board. So the GINA guidelines 2024, they always update their guidelines every year, and this is the latest one. I think somewhere in April this year, they will update again. GINA is a global initiative for asthma. Then we use the CATH guidelines for obstetric and gynecological patient care as well. And then up to date is a top up for anybody that is into internal medicine. So what's asthma? Asthma is a asthma is a heterogeneous, usually reversible disease, mostly characterized by a chronic airway inflammation, bronchoconstriction, airway wall thickening, and then increased mucus production. This usually is as a result of bronchial hyperresponsiveness. Not everybody has this bronchial hyperresponsiveness, as we'll later on see in the pathophysiology, but because of the bronchial hyperresponsiveness, these are some of the characteristics you see leading to asthma. So once these things set in, often you see it in the patient as having some respiratory symptoms such as wheezing, shortness of breath, chest tightness, cough, and these usually vary over time and intensity. And sometimes it is very variable with very variable airflow limitation. And sometimes the airflow limitation may become persistent, as you later on see in the pathophysiology, as to why the airflow limitation becomes persistent, because this is actually a reversible disease. But due to recurrent exacerbations, or let me say poor management of asthma, you get to realize that the body decides to actually remodel itself against the constant irritation that it gets. So we'll eventually see, and that leads to the airflow limitation that becomes persistent later on. So these variations are often triggered by factors such as exercise, allergen or irritant exposure. Some of these irritant exposures can be dust, strong perfumes, animal dander, pollen, and the likes. So these are just a few mentions that can give you a trigger. It could either be change in weather as well. Viral or bacterial respiratory infections as well can trigger all these things. So asthma control often changes during pregnancy. So it's not, yes, there are changes in pregnancy that happen. And an asthmatic patient that is pregnant tend to also get some changes, but they are not clear cut. So 1/3 of the time, asthma symptoms will get worse in the pregnant patient. 1/3 of the time, asthma symptoms may stay the same. And 1/3 of the time, some of them actually have improved symptoms, depending on the kind of person it is that is having the asthma. So exacerbations and poor asthma control during pregnancy have several factors that can lead to it. And a few of them include mechanical. It could be mechanical because of the protruding belly. It can push against the diaphragm, reducing the thoracic volume. And you know how important that is during inspiration. So it can be packed and it can trigger. Hormonal changes, increased progesterone. It is known that progesterone increases the hyperresponsiveness of the bronchial tree as well. So because of that, just the mere fact that your progesterone is increased, you can be prone to a lot of exacerbations. Cessation or reduction of asthma medications due to concerns by the mother and the healthcare provider, including like during active labor. And this is what I mentioned, that I gave the example about the woman that decided to stop because she read that it can be injurious to the baby. And we'll get to see what injury she's actually trying to talk about, especially with the constant steroid use in the first trimester. So because of some of these concerns, you realize that even the healthcare worker himself or herself, sometimes can be tempted to actually seize medications, but that's not right, as we'll soon see. Pregnant women appear to be particularly susceptible to the effects of viral respiratory infections. Of course, I mean, once you are pregnant, it's as if you are a little bit immunocompromised. So you are prone to some of these viral infections. So again, exacerbations can also flare up. What happens then why are we even talking about asthma in pregnancy? What are we concerned about? So poor control or recurrent exacerbations are injurious to both the mother and the baby. So for instance, the mother, it can lead to preeclampsia. You know that the mother doesn't have hypertension before pregnancy. All of a sudden, the mother is having hypertension. But then you realize that with proteinuria, of course. But then you realize that this woman shouldn't be having that. There's no probably family history or something like that. And the real pathophysiology is that you know very well the moment you have exacerbations is very stressful. Now, these stresses release, of course, the stress hormones like your cortisol, and that alone itself can actually increase your blood pressure. Or once you see the pathophysiology as to how smooth muscle becomes actively contracting, and then the narrowing of spaces, systemic wise, can lead to an increase in your afterload, meaning that the pressure that you are supposed to actually overcome before you push blood to the rest of the tissues in the body is going to increase, and that will increase your blood pressure. So that's where most likely you see preeclampsia in the mother. In the baby, again, like I said, the exacerbations are usually stressful, and so there is nothing better that induces contractions and stress on a pregnant woman. So you can have preterm delivery, premature contractions that leads to preterm delivery, low birth weight, and all of that will lead to increased perinatal mortality. So these are the things we are trying to prevent by actually talking about asthma in pregnancy today. So what are the risk factors for exacerbation in pregnancy? As pregnancy itself is a risk factor, multiparity, Black ethnicity, that one is not modifiable. As long as you are Black, that's it. Depression, anxiety, at least those can be modified. Smoking can be modified. Age, above 35 years, obesity, poorly controlled asthma, and severe asthma. All these are risk factors for exacerbation in pregnancy. So with the pathophysiology, if you look at your anatomically, on your right, you see the blue area. You notice that the smooth muscle is relaxed, the airway is open. If you look at your anatomic left, you realize that the asthmatic airway, the red part, so you see that it's an asthmatic airway during attack, where you see that there is the smooth muscle is tight, excess mucus production, and then the wall is thick. So you see that the airway is narrow. So that is exactly what happens. That's just a summary of what happens as in the pathophysiology. For instance, let's say a trigger factor comes in, an irritant comes in, maybe a strong perfume. The patient inhales. This perfume goes to the airway, irritates the cells over there, and this triggers production of there is an influx of your inflammatory cells. And these inflammatory cells predominantly are usually your eosinophils. They come in, and then immediately once they come in, then you start having goblet cell production of your mucus. Once the mucus also start producing their mucus plaque also starts forming, plugging some of the airway, blocking the airway just like that. As these mechanisms are going on around, you have the smooth muscle also contracting due to the same irritant that is there. So the airway is actually responding to the irritant that is there. When you go deep into the biochemistry of all of these, you get to understand why it is so, but I'm trying to just leave it as simple as it is. Once the irritant comes in, triggers influx of inflammatory cells, predominantly your neutrophils, your eosinophils, and then the cascade goes on to start production of your mucus and then smooth muscle contraction. All of these mechanisms lead to the narrowing of the space, and then the patient starts having difficulty in breathing, the chest tightness, cough, and all. And so when you come to the management, these are the mechanisms you target to actually reverse the process. So most of the asthmatic drugs that we have are targeting these things so that you can reverse the process. Okay, so let's talk about the phenotypes of asthma. This is just a need to know basis. I mean, this is just for an information. So I'll just rush through our own information. I'll just rush through it quickly. So the allergic type asthma is the one wherein is the most recognized asthma phenotype. That's the one that often commences in the child, that commences during childhood. It is usually associated with past or family history of allergic diseases such as eczema, allergic rhinitis, or food allergy or drug allergies. And examination of the induced sputum of some of these patients, you see that it's predominantly eosinophilic cells. And patients with this type of asthma phenotype usually respond very well with your inhaled corticosteroid treatment. That's the allergic type. That's the one we are more familiar with. The non-allergic asthma, that is usually some patients that have asthma that is not with allergy. So the cellular profile of the sputum of such patients, you see basically to be neutrophilic. So meaning the body responds to it as, so it's a foreign body. It's not like an allergic reaction. The body sees it as an insult, like maybe a viral infection or a bacterial infection of some sort. So it decides to release neutrophils to go and attack the bacteria that is there. Meanwhile, it's just something that is actually triggering the asthma. So you see predominantly neutrophilic cells. To some extent, you see eosinophils as well. So such patients with the non-allergic asthma often demonstrate lesser short-term response to the inhaled corticosteroid. So such patients, you may struggle with them when they come in. It will take time before they actually respond. You'd have to actually be increasing the stepwise ladder to the end to actually make sure that they get their relief. We also have the cough variant or the cough predominant asthma. This one also very common in children, especially children less than 3. The parents come in and the only complaint they give is that the child coughs. During the day, the cough subsides, but in the night, it is terrible. The child cannot sleep. That's just a typical way of presenting it. So evidence of variable airflow limitation may be absent apart from during bronchial provocation testing. This bronchial provocation testing you see later on, but it's not recommended in pregnant women anyways. So like I said, this is for us to know. Some patients subsequently also develop the wheezing and then the bronchodilator responsiveness, but then predominantly starts off as a cough. And then inhaled corticosteroid-containing treatment is also very effective in these patients. Then we have the adult onset or late onset asthma. These ones, particularly in women, they say it's very common in women. It happens in the adulthood. So you ask them previous history of asthma, and they tell you they've never had any experience before. And you tend to wonder, it will tempt you to want to investigate other causes, but it doesn't mean that you should not suspect asthma, because some of them present in the adulthood. They tend to be non-allergic, and then they often require higher doses of inhaled corticosteroids before they can get relief. So the other caveat here is that you have to separate it from occupational asthma, where it is just asthma as a result of exposure to work. So those that are working in the textile industries, the cotton farm, like that, some of them can come in with those kinds of asthmatic attacks. Asthma with persistent airflow limitation. So this is what I was trying to talk about early on. Some patients with long-standing asthma develop airflow limitation that is persistent or incompletely reversible. So like I said, the more the insults keep hitting the respiratory tract or the body or the system, the body tries to respond by actually remodeling the airway. And so once the airway is remodeled, it becomes, so you have, usually what happens is that you may have a lot of basement membrane thickening, smooth muscle hyperplasia and hypertrophy. Then you begin to have a lot of fibrosis happening around the airway. Now, if those things happen, it means that the air tightness, I mean, the small area within the airway narrowing becomes permanent. It makes it difficult for it to be reversed, because now fibrosis have occurred, a lot of thickening has happened, and whatever medication you are giving will only relieve the person momentarily, and it will not be very effective. So this is the type we call the persistent airflow limitation type. Then we also have asthma in obesity, which is basically asthma in obese people. So differential diagnosis. Here, I would like to point out two important ones that are concerning pregnancy. So number one is pulmonary, especially when the woman comes in as the first time. So like the person is trying to present with the adult onset type of asthma. So that's the first time the person is presenting with such exacerbations. You need to be very careful, such that you have to rule out these two important ones, pulmonary embolism and then cardiac asthma, before you can actually go ahead to treat the patient as an asthmatic case, because they present similarly. They present in similar ways, especially with during the pupurium or some few weeks postpartum. There have been a lot of congestive cardiac failure in postpartum cases that I've seen. Most of them is secondary to postpartum or puerperal cardiomyopathy. So you see them, you not see the pedal edema, you not even see the ascites in the belly. You just they will just come in the acute phase, and then because of their age, you just think that, oh no, this one is just clear-cut asthma, but you may be wrong. So those two should be ruled out very, very well before it's too late. But then the rest of the these are some of the differential diagnoses you can be considering depending on how the patient presents. I'll not go through all of them. This is just lifted directly from the GINA guidelines. So if you look at it, 12 to 39 years of age, if you are thinking about productive cough that is recurrent with recurrent infections, you are thinking of bronchiectasis. Excessive cough and mucus production, you are thinking of cystic fibrosis. If there are cardiac murmurs, you are thinking of congenital heart disease, like that. If you come to the 40 plus, you're also seeing dyspnea with exertion, nocturnal symptoms, ankle edema. Then you're thinking of the cardiac failure that I'm talking about. But like I said, most of them will come in without the edema or even the protruding belly. But then when you ask them, they'll tell you that there is PND and then there is orthopnea, probably 2 or 3 pillow orthopnea. They'll tell you all of that. So you can actually be able to rule out some of these things. Then the diagnosis of asthma. Diagnosis is based on identifying both that. So there are two patterns, both a characteristic pattern of respiratory symptoms, such as a wheezing, shortness of breath, chest tightness, cough, and variable expiratory airflow limitation. You must establish airflow limitation via the spirometry or the PEF flow meter. One of them should be able to confirm the airflow limitation for you, and then you have confirmed the diagnosis of asthma. In children below 3 years, basically because they cannot blow into those devices, after establishing this characteristic pattern, you try the bronchodilator test. If it works, then you know that you are dealing with asthma in the child. So you manage them as such until they are aged enough to actually blow in through are able to blow those equipments to measure their airflow limitation. So, but in adults and pregnant women alike, you have to establish the variable expiratory airflow limitation to confirm your diagnosis of asthma. And I know that most of us, especially those of us in the districts and other rural areas, we don't have even the PEF flow meter, peak expiratory flow meter. We don't have it, but it's just one tube that we all should have, and using it will just help establish your diagnosis. So this is just an expansion of what I just said. So when the patient comes in, you have to ask the symptoms. Do they occur variably over time and vary in intensity, or they don't? It's just one-time thing. Are the symptoms often worse at night or on waking up? Are the symptoms often triggered by exercise, laughter, allergens, cold air, etc., all the trigger factors? The symptoms, do they often appear or worsen with viral infections? So once you are able to establish these things from history, the next is to now establish the airway airflow limitation. And one thing you need to know is that the greater the variation, so meaning the greater the variation from the norm or from the baseline, or the more occasions excess variation is seen, the more confident the diagnosis of asthma. So for example, if let's say the patient comes in and then you ask the patient to blow into the spirometer, and then you realize that the FEV1 is somewhere around, let's say, 2 liters, or let's say let's use mils, 2,000 mils. And then after you give the person a bronchodilator, the person tries the spirometer again, and then the FEV1 shoots up to, let's say, 2.5 or 2,500 mils. That's what they mean by an improved. It means that the airway has improved. That just proves that you just clear the airway. That's just all it's trying to establish. And the greater the variations, like they're talking about, is that if you did the 2 liters, you measured the first time and it's 2 liters, and then you measured after the bronchodilator and you realize that the thing is now around 3 liters or 3,000 mils. It gives you a stronger confidence in the diagnosis of asthma, because it means that the airway was actually really bad And what you've done actually cleared the airway off of all the debris, and then it's now very clear for the patient to be comfortable. So if you look at the adult part, so increase from baseline in your FEV1. Your FEV is your forced expiratory volume in 1 second. So it's the amount of air you can forcibly bring out you can forcibly expire in 1 second. So if you bring that out, if that value, and it's only the spirometer that can measure that, the PEF volume is the one that the PEF flow meter can also measure. So if you don't have the spirometer and you have the PEF flow meter, you can actually use it. So if you blow into the spirometer and then you realize that there is an increase from the baseline is what you've measured already, or maybe the patient has had it before arrival, and you notice that the FEV1 has increased to more than or equal to 200 mils, okay, with a greater confidence, if the increase is more than or equal to 15% or greater than or equal to 400 mils, then you know that you've established your asthma diagnosis. But once it's above 200 mils, you know that asthma diagnosis is confirmed. It's just as simple as it is there. Okay, it's different from children, but we are not dealing with children right now, so I'll just skip that one. But what we need to know is that it is imperative that we confirm the diagnosis of the asthma before, we start the treatment. But I know that we don't usually do that because of the lack of these two equipments in our various facilities. Me that is talking like this, our facility, we don't have one. We'll find one. We'll find one eventually, and then and start using it. So the other way is that, so in case you've not actually had the time or the opportunity or the patience, or maybe the patient was in severe distress, and then you decided to actually relieve the patient before you actually measure the FEV1 or the PEF value, and then you realize that after doing that, the patient is fine, after which you discharge the patient. Before you discharge, you have to still, so for instance, there is increase in lung function after 4 weeks of treatment. So meaning you still have to get a baseline anyway. And then after 4 weeks of treatment, you realize that, at least from the baseline, there is an increase by more than or equal to 12%, or greater than or equal to 200 mils of your FEV1 after your daily dose of your inhaled corticosteroid treatment. So after 4 weeks, you can still measure these values and then still see whether there will be a change or not. So if you are doing within the first period and then you realize that there is no change, give the person time. 4 weeks later, you can try again. If there is increased, you can still confirm your diagnosis of asthma. There's also what we call the positive bronchial challenge test, which I said is not recommended in pregnant women, but in other adults, you can do that. Wherein this time around, instead of increasing your FEV1, you are trying to reduce it. So you trigger. So what you are trying to do is you trigger the hyperresponsiveness of the bronchial tree, and then you measure your FEV or your PEF, and then you see. And by the way, the PEF, the variability is that if it is above, sorry for taking you back, if it is above greater than or equal to 20% of the baseline. So before you blew into it, before we started the bronchodilator medication, we know the value, we put it there. And after the bronchodilator medication, you blow into it again. And then if the value is greater than or equal to 20% of the baseline, then you know that you have established the diagnosis of asthma. So I just wanted to point out these two, the first one in adults, and then if you are doing the first one, it doesn't work, you know that you can still do it after 4 weeks. And then the positive bronchial challenge, which I said is not recommended in the pregnant women. And since we're discussing pregnant women, that's why I just brought it for us to just know, and then we move on. So this is the spirometer. There are various models of the spirometer, and this is one of them. You blow in through that tube that is lying down there, and then the readings are given. This is the PEF meter I was talking about. You blow in through the opening there that you are seeing right around, yes, right here. You blow in through that. And this red dot here, you have to bring it down before you blow. So that's once the patient comes in an acute state, you push the lever, this red lever down here, and then you ask the person to blow. If the person blows and is within the green zone, then you know that the person's asthma is well controlled. If the person blows and it lands where the red dot is already around this yellow part, then you know that it's poorly controlled. If it blows and then it's just within this red zone, it means that it's an emergency. So you'll have to sort the patient out immediately. So this is just to remind ourselves about the general management in the adult, the non-pregnant woman. Before we go to the, what's the name? Before we go to the pregnant woman, we know that when the patient comes in chronic or recurrent respiratory symptoms are the symptoms typical of asthma. We've already discussed the typical symptoms of asthma. If it is a no, you just go and investigate other causes. If it's a yes, you have to do a detailed history and examination to support your diagnosis of asthma. The next question is the patient already taking inhaled corticosteroids? So maybe is the person already on treatment? If it is a yes, there is a different way, a different line to take, which we'll get to later on. If it is a no, which mostly I know in the rural areas, a lot of the asthma cases we see there, to ask them to actually even go and get the Symbicort inhaler or the Seretide inhaler is always a wahala. So basically, a lot of them are not on the maintenance medication. So you see them just coming in. So if it is a no, you ask again, does the patient have severely uncontrolled respiratory signs? Like I was saying, is it severe asthma such that the person can't even complete sentences? The person is actually nodding instead of responding. It's either short, yes, no, because the person can't speak because of how severe the respiratory symptoms are. If it is a yes, if the patient is really severely in severe distress, you skip to if the other diagnoses are unlikely, you treat empirically with your inhaled corticosteroid containing treatment. So you start your empirical treatment if the patient is in severe distress. You don't wait to start doing your spirometry or PEF tests. If it is a no, the next question is spirometer or PEF available, or is it feasible? If it is a no, you treat as if the patient was in severe condition. Start your treatment empirically. If it is a yes, you perform, if any of them is available, you perform your lung function before and after a bronchodilator. So once that is done, is the variable expiratory airflow limitation confirmed? If it's a yes, you've confirmed your asthma and you continue your treatment. If it is a no, then it means that you have to repeat the test whenever the symptoms come around. Once the symptoms come around, you have to repeat the test again. If you repeat the test and it's still the same thing, you have to consider other alternative tests and diagnosis. It's as simple as that. And once you confirm your asthma, and then you review within 1 to 3 months, including your PEF and spirometry, and then you notice that, you now start asking yourself if the symptoms of the lung function have improved. If they've not improved within 1 to 3 months of your management, it means that you need to refer the patient to a higher level for proper management. This is just an overview of how you wake up anybody that comes in with asthma in your settings. So based on that, I would like to highlight the categories of asthma just for us to know before we go to the recommendations in the pregnant woman. So when you say severe asthma, it's defined as asthma that remains uncontrolled despite optimized treatment with high dose ICS and LABA, that is inhaled corticosteroid and long-acting beta-2 agonist. So let me take you forward a little bit. So if you are having severe asthma, it means that you are no longer within the track, this circle of management. It means that you are now above step 4. So once you are above step 4, it means that you are having severe asthma, meaning that you have to be given high dose inhaled corticosteroids and with long-acting beta-2 agonists. Either you demand it or you are even giving they are giving it to you and still the asthma is not controlled. That's what we call the severe asthma. The moderate asthma is the ones at step 3 and step 4 where you need low or medium doses of your ICS and long-acting beta-2 agonists in either of their treatment tracks. Mild asthma is the one that is well controlled, obviously, with low intensity treatment. So it's usually on as needed, low dose, as needed basis treatment with ICS formoterol. So, and SABA, that is short acting beta-2 agonist. So that is the mild asthma. And this flow chart is just highlighting, let's say, the initial treatment. This is the asthma management cycle where it is said you review, you assess, and then you start. So the patient comes in, you listen to the exacerbation. And this is very effective, especially at the OPD setting. So after you've treated the patient on an acute setting, like what we discussed, what do you do next on the OPD settings? What do you do next with the patient? When the patient comes in for review, maybe the first week review, what do? You review the symptoms, the exacerbations, the side effects of the drug, the lung function, comorbidities as well. Then you assess the patient, reconfirm the diagnosis of this asthma if necessary. Check the inhaler technique, which is one of the most common causes of poor asthma control, the inhaler technique. You think it's children that have the issues, but it's the adults that actually really have the issues. You must make sure that they know how to use it before they go. And once you confirm all of those things, you see whether there's a need to modify the treatment, add something, subtract something, or instigate certain non-pharmacological methods to actually help in the patient. So this is what I was talking about. This I've just described that. The new track is what we are using now in 2024. This step 1, step 2, step 3, step 4 used to be the one that we were using back in the day. I think it was seen in basically it was seen in the 2022 version and then the 2023. But 2024, they fused step 1 and 2 together to as needed only low dose ICS formoterol. One of those ones, inhaled corticosteroid and your SABA, the correct combo inhaler you can always get is the Symbicort inhaler or the Seretide, one of them. They are very good at as step 1 actually. So, and even step 2, step 1, step 2, and even step 3. So step 1 is usually, step 1, step 2 is when your symptoms are less than 3 to 5 days a week with normal or mildly reduced lung function. So within a week, you've only seen some symptoms, maybe 3 to 5 so in 3 to 5 days, that's when you've seen certain symptoms. So it's considered as really mild. But in step 3, it means that the symptoms, you see them most days or when you wake up, or at night, once in a week or more or more, and then you are having low lung function as well. So that's the step 3, wherein you now have to change your medication, especially if it is not working. If it is working, fine. So the as needed only low dose ICS formoterol probably might not be the only thing you need. You probably would need to add the maintenance medication as well and reliever as well. We'll get to those definitions soon. So do you understand what a reliever is, the maintenance medication, what it is, and then you will take it from there. Step 4 is when you are now at the medium ICS for material part. It means the doses have been increased to the medium level. If you go back above step 4, it means that you are going to high dose ICS with long acting with your LABA. So once you get above step 4, it means that you are now in a state of severe asthma, like I discussed earlier. So that was just the general recommendations. Now let's go to the pregnant woman. What does Gina say about the pregnant woman? So in the clinical history is so if the clinical history is consistent with asthma and other diagnoses appear, but the diagnosis of asthma is not confirmed on initial bronchodilator responsiveness testing, manage as asthma. So if the patient comes in and you see that there are signs and symptoms of asthma, but then you cannot confirm it, go ahead and manage as asthma with your ICS containing treatment. That's what Gina is saying for the pregnant woman. Don't be afraid, go ahead. And during pregnancy, bronchial provocation testing is contraindicated, like I said earlier on, and it's advisable to step down ICS containing treatment. Now, although there is a general concern about any medication use in pregnancy, advantages of actively treating asthma in pregnancy markedly outweigh any risk of usual asthma medications. So the benefits, the advantages outweigh the risk. So go ahead and then manage the patient so that we save the pregnant woman's life. For this reason, using medications to achieve good symptom control and prevent exacerbation is justified even when their safety in pregnancy has not been unequivocally proven. So use of ICS, beta-2 agonists, montelukast, or thiophelline is not associated with increased incidence of fetal abnormalities. Evidence A. So that's the highest research that has been done. But then the other caveat is that as you soon see, there are also certain researches that has been done, and it is shown that prolonged use of your steroids, especially during the first trimester of pregnancy, can lead to cleft palate, cleft lip, and you also realize that some of the, especially during labor, some of these beta-2 agonists can act as tocolytics and, interfere with the contraction process as well. So all these things are the issues that people are usually looking at when they're trying to treat the pregnant woman. But Gina is saying that there are no concrete evidence of all these fetal effects that people are saying. So we should go ahead and actually treat the patient, give the patient proper treatment. The use of inhaled corticosteroid during pregnancy by women with asthma may also be protective for their against asthma in their children. So a study using administrative data reported that uncontrolled maternal asthma increases the risk of early onset asthma in the offspring. So you are not only protecting the mother, you are protecting the baby as well. Once the baby comes out, if it is really well controlled and the baby comes out, you will not be seeing the baby or the child having issues with asthma, especially during childhood. So it's still on the studies. In an intervention study with a follow-up for 4 to 6 years, the prevalence of asthma was over 50% lower in children of women with asthma who took ICS during pregnancy compared with women who did not take ICS, with the largest reduction in the prevalence of asthma in children with ICS was being taken in early pregnancy. So in early pregnancy, that's where they took the inhaled corticosteroids. So before 12 to 20, though that was a study they did, and they realized that the outcome was actually very, very helpful. Now, inhaled corticosteroids should not be stopped in preparation for pregnancy or during pregnancy. During pregnancy, monitoring of asthma every 4 to 6 weeks is recommended. So once you discharge the patient, even if you are not seeing the patient, after the first 3 weeks of follow-up, you have to be seeing the patient almost every month to see whether the patient is actually doing well with the treatment, especially with the use of the inhaler. During acute asthma exacerbations, to avoid fetal hypoxia, it is important to treat acute asthma exacerbations during pregnancy aggressively with your SABA, oxygen, early administration of systemic corticosteroids. So these are the three things for pregnant women during acute asthma exacerbations to avoid fetal hypoxia. This is how you treat the patient so that the patient is not having gasping for air. Of course, once the patient is having difficulty in breathing, it will definitely affect the fetus and you start having fetal distress. So once you see that, aggressively give your SABA, your oxygen, and systemic corticosteroids. Respiratory infections, if they are there, you have to treat accordingly as well. During labor and delivery, usual maintenance medications should be taken as needed. Acute exacerbations during labor and delivery are uncommon, but when they appear, especially when you have bronchoconstriction that may be induced by hyperventilation during labor. I told you that one of the risk factors or the risk factors that will lead to exacerbations is purely mechanical, raising the diaphragm up. So it will reduce the volume of the thoracic cavity and the patient will be hyperventilating. That hyperventilation can lead to bronchoconstriction. So when you see that during labor, you have to manage it with the same SABA, oxygen, and your steroids. Neonatal hypoglycemia may be seen, especially in preterm babies, when high beta agonists have been given within the last 48 hours prior to delivery. Yes, so this is as a result of the fact that there will be transient increase in the sugar level. So because of that, there will be your insulin will skyrocket. Once insulin skyrockets, it will now deplete all most of the glucose in the blood, and then you now be having a hypoglycemia. It's the same blood that goes to the baby. The baby comes out and you check, and then there is hypoglycemia. So it is imperative that if high doses of SABA have been given during labor and delivery, blood glucose should be monitored in the baby, especially if the baby is preterm, for the first 24 hours. So now let's go to a stepwise manner in treating a pregnant woman that walks into you. How do you manage that patient? This is from the CAT guidelines. So what you do is that you take detailed history and perform physical examination standard. Take sputum, your samples for routine labs standard. Set IV fluids, nebulize with 5 milligrams salbutamol. You may repeat after 30 minutes if there is no improvement. IV hydrocort, 200 milligrams start, which is what was given, which was what the GINA guidelines also recommended. Oxygen, SABA, intravenous hydrocort, corticosteroids, which is what they've given here. You give broad spectrum antibiotics if indicated, especially when you're dealing with an infection. Mind you, just like how diabetes is that until you control the infection that is going on, the sugar usually is very difficult to deal with. It's the same with asthma too. So if it's the infection that is the trigger factor, until that infection is really well controlled, you have issues actually dealing with controlling the asthma. Give intranasal oxygen. Once acute phase is over, after the patient has settled and everything is over, patient can go back to her previous medication as it was given. That is if the patient is already on medication. If the patient is not, then you have to start the patient at step 1 and then go from there. Long-term steroid use in the within 1 to 2 months should be avoided in the first trimester due to high associated risk for facial, cleft lip, and palate. This is what I was talking about. So this is just some research that was done, and it is seen that long-term use of steroids is associated with this, but that does not mean that you should not use, you should not treat the pregnant woman appropriately when they come in. Also, the non-selective beta agonists such as epinephrine are not also recommended because they can cause vasoconstriction and reduce fetal oxygenation. We, of course, don't use these things during asthmatic management. But epinephrine, you need it in a hypersensitivity reaction. So so that is why it has been brought in there. And hypersensitivity reaction can also be a trigger factor for what's the name? Asthma as well. So it's a double whammy, but they're just indicating that it is not recommended for you to use it. But like I said, we don't use epinephrine in the management of our asthma. It's not one of the first line or the go-to ones that we use anyways. So if this is the first time the patient is having such an attack, pulmonary embolism, cardiac asthma has serious differential diagnosis to consider, like I said earlier on. Now, in labor management in an asthmatic patient. So in labor, the patient is in labor, but then it's an asthmatic patient. Medications that were being administered before labor must be continued. It doesn't matter whether it's going to affect the contractions or whatnot. Give adequate analgesia must be given, as pains can trigger off attacks as well. So an example can be an epidural that can be given. Patient must be on IV fluids. Oxytocin is safe, neither inducing or augmenting the labor as well. Avoid prostaglandins F2 because it can cause bronchospasms, of course. Now, the second stage must be shortened. It must not be delayed. So if you realize that the patient, there is maternal exhaustion or for some reason the baby is not coming out, you quickly have to do your vacuum delivery. If your vacuum fails, you take the patient inside theater and remove the baby, because you don't have to waste your time on the second stage, because that is going to actually, it's a very dangerous phase wherein if bronchospasm starts occurring, it will be very difficult to actually manage such a patient, especially even with the child. So once the patient has been patient is done, everything is taken care of, and patient is discharged and comes back for your review a week later, there are certain questions you have to ask to see whether the asthma is well controlled, poorly controlled, or uncontrolled at all. So the daytime asthma symptoms, how many times in a week do you get them? Are there any night waking due to asthma? Yes or no, you take. The SABA reliever for symptoms more than twice a week. Do you use it? How often do you use the reliever, the inhaler? How often do you use it? Is it more than twice a week? Yes or no, you take. Any activity of limitation due to asthma. So maybe you want to run, you want to jog, you want to play volleyball, and then asthma says no, indicate. So these are the things that will tell you whether, so none of these means that the asthma is well controlled. 1 to 2 of them means that it's well, partly controlled, but poor. And then 3 to 4 of them means that the asthma is actually uncontrolled. And that is where you now have to adjust your medications according to the steps we discussed. So I think this brings me to the end of my presentation. Thank you for your audience, and God bless.
Excellent. Thank you so much. This has been a good education to all of us, and we are grateful, Dr. Jonathan. Exactly 4 p.m. on the dot, we are good to go. So without much ado, if you have any questions, I'd already indicated in the chat box if you wanted to use the chat box, but I didn't see any questions in there. So for now, we open the floor. Kindly electronically raise up your hand. I will mute you, and then you can go ahead with your question, comment, suggestion, or any particular point that you want to alert us to. So the floor is open. Just electronically raise up your hand. I can unmute you to go ahead. So questions, if you have any question, comment, just raise up your hand, and then you'll be unmuted to go ahead with the question. So whilst we are waiting for that, just to announce, I'll put up in the chat box a link to our social media channel so that if you want to have a look at this presentation, it will be uploaded onto the YouTube channel. The PowerPoint slides as well will be uploaded there. And then you can like our Facebook page or LinkedIn account so that we advertise our weekly topics there. So you get informed about our next topic that we'll be presenting. But like I mentioned, once you have joined today using a particular link, it's the same link we use every week. So just keep to that link. And then on Thursday, 3 p.m. or Friday, 3 p.m., depending on which day you are available or if you're available for both, we'll be having presentations. So on Thursday, we started with the asthma and pregnancy. Thursday coming, Dr. Pascal, who is a physician specialist at the Kolebu Teaching Hospital and a pulmonology fellow in training, would be taking us through asthma in the non-pregnant person. So make a date with us as well, coming Thursday. Kindly raise up your hand if you have any question. So it's either that we understood Dr. Jonathan very well or he's confused us that we don't have any question. I think it's the former. He's probably spoken to all of it. So we are grateful, Dr. Jonathan. Any questions? If you have questions, kindly raise up your hand. We have about 5 minutes. We can do this before we bring the curtains down for today's presentation. Yeah, so I see a question in the chat box. Once we have the platform open, feel free to raise up your hand so that you can ask your question. So Josephine Ayamga is saying that thank you, Doc, for the presentation. But can you give an example of the F2 prostaglandins? So Dr. Jonathan, examples of the prostaglandins.
Hello?
Yeah, hi.
The question again.
She's asking that if you can give examples of the prostaglandins that you mentioned.
Oh, okay. Okay. Some of them, the dinoprost is the one I've seen. Yes. So we have the dinoprost. Then we have the cloprostenol that I've not seen before. But these are the ones I know exist. So the dinoprost is the most common one I know.
Great. Any other question? We still have some time. You can put up your hand. Okay, so also to announce, I've put in the links that I've talked about. You can just click on them and then you like the Facebook page or like the LinkedIn account or subscribe to the YouTube channel. We will upload this presentation that we have had, both video and slides on the channel so that you can have it at your own convenience. All right. So in the absence of any questions, I don't see any hand up. I just want to say thank you so much for joining us for today. And a big thank you to Dr. Jonathan for taking us through asthma and pregnancy. We are grateful that you made time to teach us this. And we hope on Thursday, if you have time, you can join us, all of us on the platform. Same link, same meeting ID, Thursday, 3 p.m., asthma in the non-pregnant person. And then on Friday, we'll be having another topic in maternity. So make a date with us. And just to say thank you so much. God bless all of us. And let's keep helping people. Let's keep educating people because it is only through this that we as healthcare professionals can help improve knowledge, especially things that have to do with emergency. Today, you are the doctor, you are the nurse, you are the midwife. Tomorrow, you could be the one on the floor that you need someone to sort you out. So if that knowledge base is not built, it becomes a huge challenge. And we've lost the best of people through conditions that could have easily been prevented. So thank you so much for joining us for this week. We are grateful. See you next week. God bless all of us. Thank you so much, Dr. Jonathan. Bye-bye.
Thank you. Thank you. Bye-bye.